Hi friends, once again welcome back to the Nurse channel. So as you all know that the most awaited NIMHANS Nursing Officer recruitment examination date will be announced very shortly, and keeping to crack the NIMHANS Nursing Officer examination, we already started series named as the NIMHANS series, and you are watching the fifth set of questions, fifth series in this session. And this video also contains nearly 15 very important questions which are taken from different aspects of nursing subjects, and we have included application level questions, then questions which were asked previously for the NIMHANS examination, and the explanations what I have given for these questions are very important, because I have given such a good explanation and very important points that you have to study and you have to prepare well for the upcoming NIMHANS Nursing Officer examination. So without losing time, we will be moving on to the fifth series of this NIMHANS exam. And before that, whoever not yet subscribed our channel, I request everyone who are not yet subscribed, kindly subscribe and support our channel, and kindly enable the bell icon so that you will be notified whenever we are uploading new videos. So I am requesting you to watch the video till the end without skipping, because all the points what I am going to explain in this video is very important. So without losing time, we will be seeing the questions very fast. So fifth series of NIMHANS Nursing Officer examination. Moving on to the very first question in the series. So your first question is in the screen right now. So the question is, what will be found in the cerebrospinal fluid during the lumbar puncture to confirm the diagnosis of MS? MS stands for multiple sclerosis. So what will be the finding in the cerebrospinal fluid in patients with multiple sclerosis? So that is the question, and the options are: option number A, high amounts of IgM; option number B, oligoclonal bands; option number C, low amounts of WBC; and option number D, oblong red blood cells and glucose. So what will be the confirmatory thing that we can find in the cerebrospinal fluid of a patient with multiple sclerosis? That is the question. So the answer for this question is option number B, that is oligoclonal bands. Okay, so what is the oligoclonal bands? And in oligoclonal bands itself, we have IgG and IgM bands that we will be discussing in the explanatory session. So we know that multiple sclerosis, it is a degenerative disease in which the insulating covers called the myelin sheaths of the nerve cells in the brain and spinal cord are damaged. So it is a degenerative demyelinating, that is a myelin sheath are getting damaged in multiple sclerosis. So signs and symptoms are associated with that. So I am not going in depth about the multiple sclerosis signs and symptoms. That is also very important. So we will see the cerebrospinal fluid and its findings. So testing of the CSF obtained from a lumbar puncture can provide evidence of chronic inflammation in the CNS. So the CSF is tested for oligoclonal bands of IgG. So this is very important. Oligoclonal bands of IgG on electrophoresis, which are inflammation markers found in 75 to 85% of people with MS. So IgG bands, oligoclonal bands, can be seen in the electrophoresis of CSF in multiple sclerosis. And we know that oligoclonal bodies, these are especially important for multiple sclerosis, because in MS normally only OCBs made of immunoglobulin G antibodies are considered, though sometimes other proteins can also be taken into account, like lipid specific IgM. Okay, IgM. The presence of IgM is associated with more severe colds. So two information you are getting: oligoclonal bands will be present in the CSF. In that, oligoclonal IgG are the most common, which can be seen in 75 to 85% of the people with MS. Along with that, if we are seeing IgM oligoclonal bodies, that means that the course of the disease is more severe. Okay, so these are some additional information that we are getting out of this question. So that's all regarding the first question. Now we will move on to the second question in the series. Which patient below is at most risk for an injury or toxicity due to being prescribed a benzodiazepine? So here the question is regarding the benzodiazepine toxicity or overdose. So who is at maximum risk, most risk for developing this toxicity? That's the question. And the options for you are: option number A, a 28-year-old with a history of seizures; option number B, a 78-year-old receiving dialysis; option number C, a 45-year-old who is post-operative day 2 from a femoral popliteal bypass; and option number D, a 36-year-old receiving treatment for gastritis. So think about benzodiazepines, its side adverse effects and toxicity, and then you can answer this question very easily. So if you prioritize the options, then you will come to the conclusion that option number B is the answer for this question. That is a 78-year-old patient receiving dialysis. Okay, so we will have a look on benzodiazepines, its toxicity and the toxicity levels. So benzodiazepines, these are a class of antidepressants which are a class of depressant drugs which are prescribed to treat conditions such as anxiety disorders, insomnia, and seizures. So benzodiazepines are depressants that enhance the effect of neurotransmitter gamma aminobutyric acid GABA at the GABA A receptor, resulting in sedative, hypnotic, anxiolytic, anticonvulsant, and muscle relaxant properties. So some additional information you are getting out of this question: benzodiazepines, these are the depressants, and its effect is on the GABA, and thus it can host sedative, hypnotic, anxiolytic, anticonvulsant, and muscle relaxant properties. Okay, so that is in short about some information about the benzodiazepines. So we will come to the toxicity. That was the question I have asked. So the classic symptoms of toxicity include slurred speech, then ataxia and altered mental status. Slurred speech, ataxia and altered mental status. And coming to the answer of our question, older adults are at risk for toxicity, dependence, and injuries related to benzos usage. Okay, so in addition, this patient has compromised renal function and needs dialysis, which increases their risk for toxicity or injury as well. Okay, so this throw you some light on the information regarding the answer for the question I have asked. Okay, so that's all regarding the second question in the series. Now we will be moving on to the third question. During administration of the fluids for a patient in neurogenic shock, the nurse will monitor the patient closely and immediately report which among the following. So the question is regarding neurogenic shock, and you are caring for the neurogenic shock patient and you are administering fluid for this patient. So if the patient is presented with any of the symptoms what I am going to give, so which one you will be more alert? Okay, so that's the question. And the question options are: option number A, increase in blood pressure; option number B, high CVP and PAWP, pulmonary artery wedge pressure; option number C, urinary output of 300 ml in the past 5 hours; and option number D, mean arterial pressure or MAP 85 millimeter mercury. So think about neurogenic shock, its signs and symptoms, and why we need to administer fluid in neurogenic shock. So those things you have to, that points have to come in the mind, and you can answer the question. And so what is the answer? So the answer is option number B again, that is high CVP and PAWP. Okay, high CVP and PAWP. Why there is no increase in the blood pressure and other options? So that we'll be discussing now. So we know that neurogenic shock, it is a combination of both primary and secondary injuries that lead to loss of sympathetic tone. So here there is a loss of sympathetic tone and thus unopposed parasympathetic response driven by the vagus nerve. Okay, so again, so many information you are getting in neurogenic shock. There will be compromised sympathetic tone and there will be parasympathetic overactivity by the vagus nerve. Okay, so that is happening in neurogenic shock. So the sympathetic nervous system is unable to stimulate the nerves that regulate the diameter of the blood vessels. Okay, so there is a loss of vasomotor tone which causes a massive vasodilation. So in as a neurogenic shock, because of the sympathetic activity and deterioration, there will be vasodilation because of the loss of vasomotor tone. So systemic vascular resistance will decrease and hypotension will occur. So neurogenic patients will be presented with hypotension. Okay, and other hallmark signs and symptoms of neurogenic shock are, so as we told, hypotension, then bradycardia. So this is also very, very important: hypotension, bradycardia, hypothermia, and warm and dry extremities. Warm and dry extremities. Why? Means this is due to the vasodilation, what already we have explained, and blood pooling and will be found in the extremities. Okay, so there will be warm, dry extremities will be found in the neurogenic shock, and its reason also I have explained. Okay, so I'm giving you some clues for your preparation. We can compare it with other types of shock. We have hypovolemic shock, cardiogenic shock. There are so many types of shocks are there. So those signs and symptoms you can compare. So in neurogenic shock, there will be warm and dry extremities. That is the reason is the vasodilation and blood pooling. Okay. So we know that in the options what we have told that the answer for this question is high CVP and high PAWP. So the option number B would indicate the patient is in fluid volume overload. Okay, so there is a fluid volume overload. Remember that patients in the neurogenic shock usually have a normal blood volume. There is no change in the blood volume. So if fluids are ordered to help increase the blood pressure, they should be used with extreme caution because fluid overload can occur. So an increase in the central venous pressure and pulmonary artery wedge pressure would indicate this. Okay, so if there is a fluid overload, there will be increase in the CVP and PAWT. And these pressures shows the filling pressure in the heart. So that's why we have chosen the option B as the right answer for the question what I have asked. Okay, so we'll have a small information regarding the normal CVP is 8 to 12 millimeter mercury, normal PAWP is 4 to 12 millimeter of mercury, and normal mean arterial pressure is 70 to 100 millimeter of mercury. So mean arterial pressure what I have given in the question is correct. Okay, so these are some important normal values that you have to keep in mind. Okay. So again, bunch of information you have got from the third question. Now we will be moving on to the fourth question in the series. So question is, which among the following signs and symptoms are characteristics of Guillain-Barré syndrome? So this question is regarding the Guillain-Barré syndrome. So that is the characteristics. Okay. So again, slightly confusing question. So the options are option number A, unilateral and descending pattern that starts in the lower extremities. Then option number B, symmetric and ascending that start in the upper extremities. Option number C, asymmetric and ascending that starts in the upper extremities. And option number D, symmetrical and ascending that starts in the lower extremities. So what is the answer for this question? So you should know thoroughly about the GBS, Guillain-Barré syndrome, and whether it's a asymmetrical, unilateral or bilateral, or whether it is a ascending or descending, where it starts. Those things I can explain in the explanation of this question. So first of all, we will see the answer. We know that Guillain-Barré syndrome, it is symmetrical and ascending pattern that starts in the lower extremities. Okay, so we know that Guillain-Barré syndrome is a rapid onset muscle weakness caused by the immune system damaging the peripheral nervous system. So it is an autoimmune disease. So immune system damage is happening to the peripheral nervous system, and as a result, there is a rapid onset of the muscle weakness can happen. Okay, so just this is a brief explanation. You have to learn thoroughly regarding these symptoms. These disease conditions. So we know that typically both sides of the body are involved. Okay, so it is a bilateral, and the initial symptoms are changes in the sensation or pain, often in the back, along with muscle weakness, which is beginning in the feet and hands and often spreading to the arms and upper body. Okay, so it can start in the feet or in the hands, but most commonly it will start in the feet and then spreading to the arms and upper parts of the body. So GBS signs and symptoms will most likely start in the lower extremities, and it will be symmetrical and will gradually spread upward, that is ascending pattern, to the head. Okay, so I think it is clear that option why we have chosen the option number D is clear by this explanation. So with that, we will be moving on to the next question in the series from OBG, and again an application level question. A patient with HIV is 6 weeks pregnant. So what would you educate the patient about? So you got a patient with HIV positive and she is 6 weeks pregnant. So what is the most priority education that you will give to the patient? Okay, 6 weeks, that is very important key term. So the options are option number A, they have to practice safe but total abstinence from the sexual intercourse during the pregnancy. Then option number B, HIV cannot be passed to the fetus. Option number C, how breastfeeding will help the newborn after the birth. And option D, HIV is only passed through the blood. So among these, which education you will focus on for this patient, that is HIV positive 6 weeks pregnant lady? 6 weeks. So what is the answer? So the answer for this question is option number A, that is they have to practice safe but total abstinence from the sexual intercourse during the pregnancy. So again, some more information I can pass to you through the explanation from this question. So we know that HIV can be transmitted from an infected mother to the neonate in 3 circumstances. Okay, these 3 circumstances are very, very important. The first one is through the placenta, across the placenta during the pregnancy, that is in utero transfer. Then at birth, during the birth, due to the fetal contact with the infected maternal blood or the genital secretions. And the third way is the postnatally through the breast milk. So in utero, at birth, and postnatally, that is through the breast milk also. Okay, so these are the three situations where the neonate can get HIV infection from the HIV infected mother. Okay, so in general, the lower the viral load, the lower the risk of transmission. Okay, that is sure. So for this reason, ART, that is antiretroviral treatment, is recommended throughout the pregnancy so that the viral load levels remain as low as possible and the risk of transmission also will be reduced. So one more information, that is the antivirals that we are regularly using, especially for the pregnant ladies, are like zidovudin, lamdovudin, etc. type of drugs are there. And at the end of at the time of third trimester, IV zidovudin also can be used. So the doses and those things you can refer later. So these patients need to be educated that the repeated exposure to HIV during the pregnancy can increase the risk of transmission to the fetus. Okay, so this is the important thing, and this was the question I have asked. So we have to educate them that repeated exposure then again can increase the viral load and thereby increase the risk of transmission to the fetus. So that's why we are telling that abstinence, complete abstinence of the sexual intercourse or the safe practice they have to follow. Okay, that is to reduce the viral load and thus to prevent the transmission or reduce the transmission to the neonate. Okay. So moving on to the sixth question from the from the GIT. So the question is, following the Billroth 2 surgery, which of the following should be excluded from the plan of care? Should be excluded. So here the options are: patient has undergone Billroth 2 surgery, and what should not be included in the plan of care. So you know what is Billroth 1, Billroth 2 surgeries. So that will be explaining in the explanatory section. So the options we will see first. The first option, consuming small frequent meals that are high in protein. Small frequent meals that are high in protein. Then option number B, sit upright for at least 30 minutes after the meals. Option number C, avoiding fluids with meals. And option number D, reducing the amount of simple carbohydrates in the diet. So what you will be excluding out of these options, what you will be excluding for the patient, post-operative patient Billroth 2 surgery? What is the answer? So the answer for this question is option number B, sit upright for at least 30 minutes after surgery. So these things that we are stressing for preventing the complication, and you know that complication is the usually after the gastric surgeries are the dumping syndrome. So we'll be explaining now. So what is a Billroth 1 and Billroth 2, that I am giving you a small information. So Billroth 1, which is normally known as the Billroth operation 1, is an operation in which the pylorus, the stomach's first part, is removed and the distal stomach is anastomosed directly to the duodenum. So here the stomach pylorus is anastomosed to the duodenum. That is Billroth 1. So whereas in Billroth 2, it is an operation in which a partial gastrectomy is done, that is the removal of the stomach is performed, and the cut end of the stomach is closed and the duodenal stump is closed and gastrojejunectomy is created. Okay, so duodenum is bypassed and the gastrojejunectomy is done in Billroth 2 procedure, and in Billroth 1 gastroduodenostomy is done. Okay, so this is the difference between Billroth 1 and 2. So coming to the question, so we know that dumping syndrome, this is a complication, and dumping syndrome occurs when food, particularly the sugar, sugar moves too quickly from the stomach into the first part of the small intestine. Okay, so we know that in the options also I have given that we have to reduce the sugar intake. So that is a correct option. Okay, so particularly sugar moves too quickly from the stomach to the first part of the small intestine, and this rapid transit leads to a cascade of symptoms such as abdominal cramping, nausea, diarrhea, and even palpitations. So this is known as the dumping syndrome, and for management of dumping syndrome, the opposite of sitting upright is often recommended. Okay, so here we have chosen the option we should avoid sitting upright for 30 minutes immediately after the field. So what will happen, sir? Patients are usually advised to lie down or recline for about 30 minutes after the eating, and this can slow down the transit of the food from the stomach to the small intestine and thus reducing the chances of developing dumping syndrome and its associated signs and symptoms. Okay, so that is the reason why we are not allowing the patient to sit upright after having food. Okay, so in dumping syndrome, the stomach empties too rapidly into the stomach small intestine, and there will be the osmotic load in the small intestine rises very quickly, and it can cause the fluid to be pulled into the intestine. So this disrupts the digestion and absorption, which can lead to the characteristic symptoms what I have explained in the last slide. Okay, so this is a pathophysiology. There is a osmotic load is happening to the small intestine, and that can resulting in the fluid overload, gushing of fluid, and thus disrupting the absorption, and other characteristic symptoms what I have explained is happening. Okay, that is dumping syndrome. Okay, so I think that also is clear. You are getting information regarding what is Billroth 1, Billroth 2, gastric surgery complication, dumping syndrome, and how to prevent that. Okay, so that's all regarding that question. We will be seeing the 7th question, and the question is in the screen right now. Which action would have the highest priority for a patient with gouty arthritis? So the condition is gouty arthritis here, and which is the highest priority for a patient with gouty arthritis. From the options what I am going to give, and option number 1 or A, that is apply hot compresses to the affected joints. Apply hot compresses to the affected joints. Option number B, stress the importance of maintaining good posture to prevent deformities. Then option number C, administer salicylates to minimize the inflammatory reaction. And option number D, ensure an intake of at least 3 liters or 3000 ml of fluid per day. So what is the answer? For gouty arthritis, you will choose which option from this for the management. So the answer is obviously option number D, that is you have to ensure an intake of around 3 liters of fluids in a day. Why? So that will be seeing now. Gouty arthritis or the gout, it is a form of inflammatory arthritis which is characterized by the recurrent attacks of red, tender, hot and swollen joints which are caused by the deposition of needle-like crystals. Okay, needle-like crystals of uric acid which is known as the monosodium urate crystals. So again, many points. So gout affecting the joints and deposition of needle-like crystals of uric acid, and these uric acid crystals are known as the monosodium urate crystals. Okay, so we know that the patient should be urged to increase their fluid intake to prevent the development of urinary uric acid stones. Okay, so this is the first thing. With the increased fluid intake, what we can prevent is urinary uric acid stones can be prevented by increasing the urine intake. Then gout patients and hyperuricemic patients, they are advised to drink 2 to 3 liters of water every day, and the water intake should be spaced and be done consistently throughout the day. Okay, so 2/3 of the uric acid in the human body are excreted through the kidneys. Okay, so flushing out of urine should happen. Flushing out of the stones or the uric acid can happen with the frequent regular hydration of regularly 2 to 3 liters of water in a day. Okay, so here comes the the answer for the question what we have discussed just now. Okay, and drinking water can help reduce the swelling and inflammation. So another important thing, swelling, inflammation, then flush the uric acid crystals from the system and decrease the risk of recurrent gout attacks. So dehydration can trigger a gout attack. Okay, so these are the benefits. So first of all, we have explained drinking water can reduce the urinary uric acid stones, then it will reduce the swelling and inflammation. It can flush out the uric acid through the kidneys. Okay, so these are the benefits of drinking 2 to 3 liters of water in a day for a patient with gouty arthritis. Okay, so that's all regarding the 7th question. And one more information I can give regarding this. So there are certain medications that can raise the levels of uric acid and thereby increasing the risk of gout, and these includes the diuretics. Okay, so substances that increase the production of urine, and acetyl salicylic acid, example aspirin like drugs. These things can increase the levels of uric acid, so these things also should be avoided. This is also very important, because questions can ask from any parts. Okay, so that's all regarding the 7th question. So here comes the 8th question of our series, and the 8th question from gynecology, and the question is, lymphedema after mastectomy can be prevented by dash. So lymphedema, you know that it is a possible complications after the mastectomy, and that can be prevented by which intervention? That's the question, and the options are: option number A, ensuring patency of the wound drainage tube; option number B, placing the arm on the affected side in a dependent position; option number C, restricting the movement of the affected arm; and final option, frequently elevating the arm of the affected side above the level of the heart. So options are slightly confusing, but it's very important. So mastectomy, after mastectomy, lymphedema can be prevented by which among the following interventions? So what is the answer? So here the two options that can be get confused, whether the affected side arm should be kept in the dependent position or the above the heart level. So the answer is, we have to frequently elevate the arm of the affected area above the level of the heart. Okay, so we know that breast cancer related lymphedema, it is a chronic syndrome of abnormal swelling and multiple symptoms resulting from abnormal accumulation of protein rich lymph fluid in the interstitial tissue spaces due to an imbalance between lymph fluid production and transport. Okay, so there will be imbalance between the lymph fluid production and the transport, and as a result there will be accumulation of protein rich lymph fluid in the interstitial tissues, and that will be evident as the lymphedema after the breast cancer. Okay, so elevating the arm above the level of the heart promotes the good venous return to the heart and good lymphatic drainage, thus preventing the swelling. Okay, so arm should be elevated above the heart level. Okay, so that's all regarding the mastectomy and the prevention of lymphedema. Now we will move on to the 9th question in our series. So the question is, which result would the nurse most likely expect to find in a client with chronic renal failure? So this is regarding the CKD or the chronic renal failure, and what will be the most expected result that can be seen in a renal failure patient. So these are some lab values. So option number A, BUN of 10 to 30 milligram per deciliter, potassium of 4 milliequivalent per liter, creatinine 0.5 to 1.5 milligram per deciliter. And option B, decreased serum calcium, blood pH of 7.2, potassium 6.5 milliequivalent per liter. Then option number C, BUN of 15 milligram per deciliter, increased serum calcium, creatinine 1 milligram per deciliter. And the final option is BUN of 35 to 40 milligram per deciliter, potassium of 3.5 milliequivalent per liter, and pH 7.35, and along with that decreased serum calcium. So just think about the chronic renal failure and what will be the blood parameters. So this is an application level question, so you should understand and you should know what are the normal blood values of BUN, potassium, creatinine, sodium, calcium, everything. Okay, so what is the answer? What is happening in a chronic renal failure? So you know that the answer is option number B, that is that there will be decreased serum calcium, blood pH will be 7.2, and the potassium is 6.5 milliequivalent per liter. Okay, so we will have a small explanation regarding this question. So we know that chronic renal failure, it is usually the end result of gradual tissue destruction and loss of renal function. This is the end result. Okay, that's why it is known as the chronic renal failure. So with the loss of the renal functions, the kidney ability to regulate the fluid and electrolyte balances and acid base balances will not be functioning. Okay, so the serum calcium decreases as the kidneys fail to excrete phosphate. So the first thing we are explaining now, the serum calcium will be decreasing, that is hypocalcemia will be there as the kidneys fails to excrete the phosphate, and potassium and hydrogen ions are retained. So there will be hyperkalemia also will be there, and hydrogen ions are retained. Okay, so that will comes the pH imbalances. Okay, so in short we can tell that there will be calcium, hypocalcemia will be there, hyperkalemia will be there. Okay, and we know that the normal values I will be explaining now. So the total blood calcium level is 8.5 to 10.5 milligram per deciliter, and in that calcium itself we have two values, that is a total blood calcium and the ionized calcium. Ionized calcium level is 4.65 to 5.2 milligram per deciliter. And we know that one diagnostic clue that helps differentiate the chronic kidney disease from the acute kidney injury is the gradual rise in the serum creatinine. Okay, so over several months or years, as opposed to a sudden increase in the serum creatinine level. So in the options we have given the creatinine of value of 6, that means it is a high creatinine value, and that indicates a CKD. And the development of high creatinine value, if it happens in all on a sudden, that will be the AKI, and if it is gradually increasing over several months or years, then that is known as a CKD or the chronic kidney disease. Okay, so that's all regarding that question regarding the chronic renal failure. Now another question regarding the diabetes mellitus. So nurse is educating client with type 1 DM and hypoglycemia at home can be treated by ingesting dash. Okay, so the nurse is educating client with type 1 DM and hypoglycemia at home can be treated by ingesting dash. We know that many of the diabetic patients will go to hypoglycemia in one or the other stages when they are at home. So how they can manage hypoglycemia at home, that is a question. So the first option is 2 to 5 gram of a simple carbohydrate. Option number B, 10 to 15 gram of a simple carbohydrate. Option number C, 18 to 20 gram of a simple carbohydrate, and the final option is 25 to 30 gram of a simple carbohydrate. So in the explanatory session, I will be explaining regarding the amount of sugar, how much they have to take, if the candy they are using, how much they have to take, or the fruit juice means how much ounce or how much ml they can eat, drink. Those things I will be explaining now. So coming to the answer of this question, how much they have to ingest? They have to ingest a quantity of 10 to 15 gram of a simple carbohydrate. So to reverse the hypoglycemia, so as per the recommendations of the American Diabetes Association, ingesting of 10 to 15 gram of a simple carbohydrate such as 3 to 5 pieces of hard candy. Okay, so this is important. 3 to 5 pieces of hard candy or 2 to 3 packets of sugar. That small packet we used to get, no, that will be around 4 to 6 teaspoon, or 4 ounce of fruit juice. Okay, 4 ounce of fruit juice. So if necessary, this treatment can be repeated in another 15 minutes. Okay, so this is the calculation: 10 to 15 gram simple carbohydrate, or 3 to 5 pieces of hard candy, or 3 packets of sugar, or it comes to 4 to 6 teaspoon of sugar, or 4 ounce of fruit juice. Okay, so other options we will see that ingesting only 2 to 5 gram of a simple carbohydrate means it does not raise the blood glucose level, which is sufficient for maintaining the balance. So ingesting more than 15 gram may raise it above the normal and it can cause hyperglycemia. So as per the American Diabetes Association recommendation, this is the plan. Okay, so I think that is clear for you. Now we will move on to the next question in our series. So your 11th question in the series is on the screen right now. So the question is, which outcome indicates that treatment of a male client with diabetes insipidus has been effective? Okay, so the options are: option number A, fluid intake is less than 2500 milliliter per day. Then urine output measures more than 200 ml per hour. Blood pressure is 90/50 millimeter mercury. And the option number D, the heart rate is 126 beats per minute. So this is again an application level question regarding the diabetes insipidus. So we are giving treatment for a diabetes insipidus patient, and the patient's outcome will be what among these options? That is a question for you. So what is the answer? So think about diabetes insipidus. What is happening in diabetes insipidus? And you can answer this question. So the answer is option number A, that is fluid intake is less than 2.5 liter per day. Okay, so first of all, we'll have a small discussion about the diabetes insipidus. So diabetes insipidus is a disease in which the secretion of or a response to the pituitary hormone vasopressin is impaired, resulting in the production of very large quantities of diluted urine, often with dehydration and insatiable thirst. So there will be problem will be affecting the vasopressin functioning, which results in the reduction in the production, and there will be reduced action of the vasopressin, and as a result there will be large quantities of diluted urine will be passed, and dehydration and thirst will be there for the patient. So after the treatment, what will happen? So diabetes insipidus is characterized by polyuria. That means up to 8 liter per day will be voided out, constant thirst, and an unusually high oral intake of fluids. So the treatment with appropriate drug should decrease both oral fluid intake and urine output. So this is the goal. After the treatment, there should be reduction in the oral intake of the fluid, and at the same time there will be reduced urine output also. So a urine output of 200 ml per hour indicates continuing polyuria. That means the options I am just discussing. So we have come to the answer. That means if the patient is taking less fluid in a day, then that indicates that the treatment is effective. So if the urine output is 200 ml per hour, then it indicates continuing polyuria. Okay, because 50 ml, 50 to 70 ml per hour is the normal what we have to say. Then a blood pressure of 90/50 means this is hypotensive, and a heart rate of 126 means it is a tachycardia, which indicates compensation for the continued fluid deficit, suggesting that the treatment has not been effective. So this is already the compensatory mechanism have worked, like the BP has reduced, the heart rate has increased, and this suggests that the treatment is not effective. Okay, so the answer is the fluid intake of the patient has reduced. That is the answer. Okay, so we will see the 12th question in our series. Which of the following laboratory test results indicates to the nurse that the client needs an increase in the dosage of warfarin? So here the patient is in warfarin, and which lab value will give an idea that the dosage of the warfarin is not adequate for the particular patient. So the options are: option number A, APTT of 38 seconds, option number B, INR of 1.1, then option number C, PT of 22 seconds, and option number D, D-dimer negative. So what lab value among this indicates that the dosage of warfarin what is receiving for the patient is not adequate? So think about warfarin. So which tests need to be done for testing the adequacy of warfarin dosage? then you can come to the answer. So the answer for this question is option number B, that is INR of 1.1. Okay. So you may confuse with the APTT and PT. So I will be explaining that now. So we know that INR of 1.1 is within the expected reference range for a client who is not receiving warfarin. So 1.1 INR means that is a normal. So in a healthy people, INR of 1.1 or below is considered as normal. So for a warfarin receiving patient, this means that is not be normal. So this value is subtherapeutic for the anticoagulation therapy. So the nurse should expect the client to receive an increased dosage of warfarin until the INR is 2 to 3. So the goal of treatment or the INR goal is like 2 to 3 in patients receiving warfarin. So this is very important. Okay, so this is a normal value. It should be less than or equal to 1.1 for normal individuals. Then another options also we will see. What is APTT? So APTT is monitored for clients receiving heparin therapy. Okay, this was asked very frequently in many competitive exams. So APTT is monitored for the clients receiving heparin therapy, and an APTT of 38 seconds is within the expected reference range for the clients not receiving heparin therapy. That means they have, the reference range for the APTT in a normal individual is 30 to 40 seconds. So 38 means that will be within the normal range, and that does not shows that the treatment is adequate. Okay, so that is regarding the APTT. And next is the PT. What is a PT? That's a prothrombin time of 22 seconds is above the expected reference range for a client receiving warfarin, and this result indicates that the client is at an increased risk of bleeding, because the normal range for the PT is 10 to 13 seconds. Okay, 10 to 13 seconds, and the option what we have given is PT of 22 seconds. So that also is not correct. Okay, so that's all regarding that question. So you are getting information regarding warfarin therapy. In that warfarin therapy, how much INR to be maintained, and what is the normal ranges of INR, APTT, PT, etc. Okay, so that's all regarding that question. And one more option we missed, that is a D-dimer. So during the COVID time and all, we were very much aware of this investigation. So D-dimer, it is a dimer, that is a fibrin degradation product, which means a small protein fragment which is present in the blood after a blood clot is degraded by fibrinolysis. So whenever there is a blood clot and that blood clot is degraded by the process of fibrinolysis, then in the blood we can see a dimer, that is known as the D-dimer. Okay, that is known as the D-dimer. So what is a normal D-dimer? So a negative D-dimer test indicates that the absence of a pulmonary embolus or deep vein thrombosis, and it is used to determine the dose, and it is not used to determine the dosage for warfarin therapy. That is not related to our question at all. So the normal range is 0 to 0.5 milligram per liter of blood. Okay, so this is about the D-dimer. So you are getting some information regarding the D-dimer also. So with that we can move on to the next question, that is the 13th question in our series. So this is regarding a transfusion reaction. So which of the following findings should the nurse identify as an indication of a febrile transfusion reaction? So you know that there are several transfusion reactions. So the question is regarding the febrile transfusion reaction. So the options are option number A, temperature change from 37 degrees Celsius pre-transfusion to 37.2 degrees Celsius, or 98.6 degree Fahrenheit to 99 degree Fahrenheit. So this is the first option. Option number B, the current blood pressure is 178/90 millimeters of mercury. Then option number C, heart rate changes from 88 per minute, which was pre-transfusion, to 120 per minute. And option number D, client report of itching. So question, you should be very careful. The question is regarding the febrile transfusion reaction, not regarding any other transfusion reaction. So don't be confused with the option. So what is the answer? So the answer for this question is option number C, that is the heart rate changes from 88 per minute pre-transfusion to 120 per minute. So why temperature was not the answer for this question? So that we will be seeing in the explanation session. So there are several types of transfusion reactions. This is a point what I am giving to you to work more. Okay, so you have to work in these points more. Like there is acute hemolytic reaction, delayed hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, anaphylactic reactions, simple allergic reactions, septic transfusion reactions, then transfusion related acute lung injury or the TRALI, and then TACO, that is transfusion associated circulatory overload. So these are the different types of transfusion reactions that you have to refer later. Then coming to our answer, So in febrile non-hemolytic transfusion reaction, a temperature increase of 1 degree Fahrenheit, okay, 1 degree Fahrenheit should be there, or 0.5 degrees Celsius is an indication of a febrile transfusion reaction, okay. So temperature increase of 1 degree Fahrenheit should be there, but in our question there was not that much difference was not there, so that's why we didn't choose that option. And the symptoms of febrile non-hemolytic transfusion reaction may also include chills, rigors, increased respiratory rate, tachycardia, change in the blood pressure, that means a hypotension, anxiety and headache, okay. So these are the other things that we can see, okay. So tachycardia was one option what we have given in the options, so that's why we have chosen that answer, okay. So that is febrile non-hemolytic transfusion reaction. So moving on to the second last question, that is from the psychiatry. A selective serotonin reuptake inhibitor targets which part of the brain? So we know that SSRI is what we are giving regularly for the psychiatric patients with some conditions. So this SSRI is where it is affecting in the part of the brain. So that's the question, and the options are option number A, basal ganglia, option number B, frontal cortex, option number C, hippocampus, and option number D, putamen. So where the selective serotonin reuptake inhibitors acts on the brain. So what is the answer? So the answer for this question is very simple, option number B, that is a frontal cortex. So SSRIs are targeting the prefrontal cortex to Raphe circuits. Okay, this is the circuit. This is the pathway of the selective SSRIs action target, okay. So I'll be explaining some of the brain areas where some medicines are acting. So in the hippocampus of the brain, mainly the antidepressants are acting, like it may reduce the structural shrinkage in the hippocampus and the prefrontal cortex. They may also promote new cell growth in the hippocampus, and another examples are like stimulants. It may enhance the hippocampal function, and alcohol also may enhance the hippocampal function. So these are the drugs: antidepressants, stimulants and alcohol, some medicines which are acting on the hippocampus. Then another option was regarding the basal ganglia. So the basal ganglia are the site of most dopamine neurons in the brain. So antipsychotic drugs target the basal ganglia, and exposure to the antipsychotic medications has been linked to structural brain changes in the basal ganglia. So mainly antipsychotics, they are acting on the basal ganglia. These are some very short peripheral information what I am giving you for the preparation of NIMHANS examination. And with this question, some brain areas and where that brain areas which all medicines are acting, what we have explained. So coming to the final question in our series, the 15th question, which diuretic is used in open angle glaucoma? So the question is regarding open angle glaucoma management with a diuretic, and which diuretic can be used. So the options are option number A, furosemide, option number B, torsemide, option number C, acetazolamide, and option number D, amiloride. So which diuretic is used in open angle glaucoma, and why diuretics are used in open angle in glaucoma? So that we'll be discussing. Before that, we'll see the answer for this question. Answer is option number C, that is acetazolamide. So the glaucoma, you know that glaucoma, it is a group of eye diseases that leads to the damage of the optic nerve, which is important for transmitting the visual information, okay, that you know. So this damage is often caused by increased pressure within the eye, which is known as the intraocular pressure, and may cause vision loss if left untreated, okay. So there will be increased intraocular pressure that can resulting in the damage to the optic nerve and associated symptoms. So, okay, so there we have two types of glaucomas, that is open angle glaucoma and closed angle glaucoma. So in open angle glaucoma, the drainage is impeded, causing the liquid to accumulate, and pressure inside the eye will be increasing. So this elevated pressure can damage the optic nerve, what we have already explained. But in the closed angle glaucoma, the drainage of the eye becomes suddenly blocked. Okay, this is happening very suddenly, leading to a rapid increase in the intraocular pressure, and this may lead to intense eye pain, blurred vision and nausea. So it is a closed angle glaucoma. It is an emergency requiring immediate attention. Okay. So I think you got the difference between open angle and closed angle glaucoma. Closed angle glaucoma, it is a sudden happening of the blockage, and thus leading to increased intraocular pressure. Then coming to the answer for our question, that is the acetazolamide, otherwise known as the Diamox trade name. So it reduces the rate of aqueous humor formation by direct inhibition of the enzyme carbonic anhydrase on the secretory ciliary epithelium, causing causing in turn a reduction in the intraocular pressure. So there will be a reduction in the production of the aqueous humor. So that much at least you should remember. So this is the pathophysiology what I have explained here. So likewise the intraocular pressure will be reduced and the glaucoma will get relieved with the help of acetazolamide, otherwise known as a Diamox. Okay. So with that question from the ophthalmology, we are coming to the end of another session, another very, very important, very, very effective and informative session of our NIMHANS series. So hope you enjoyed this video and I believe that you got some new information about some topics from this session. So request everyone to watch our upcoming videos, and for that what you have to do is please keep in touch with us and kindly share about this platform to your friends, and we'll see you soon with the next series very shortly. Till that time, goodbye.